Hi, this is Elizabeth, and this is my skull trigger, also known as my sinus and mandible trigger. I have my console set up for my sinus views and my mandible views and my orbit views, which I'll be adding in as an extra. I don't know why I'm scratching my head. I'm going to go over here and grab some alcohol wipes. I'm going to set my room up for my patient. I'm going to clean the bucky because everybody's nasty chins have been on there. And we also have this. Nice and clean. I have my tube set up at 40 inches, which is the SID for all of our projections that we will be shooting today. It's detented to the wall bucky. We're going to be doing these uprights, and sinuses you need to show the air fluid levels, and yeah. Yellow, okay. So I'm ready to go get my patient, Miss Ramirez.
Hi.
Hi. Nice to meet you. My name is Elizabeth.
My name is Pat.
Come on, Pat. Come on back. Go ahead and give me your full name and your date of birth, please.
Pat Ramirez, 2/13/65.
Okay, Pat, thank you. So I'm going to be going ahead and taking a couple pictures of your mandible, your sinuses, because I know you're very congested probably.
I don't know.
Then your orbit, since I know you got some problems. Is there any chance you could be pregnant? You could be pregnant. No, it's a silly question, but we have to ask.
No.
Okay, good. So, tell me a little bit about why you're here today.
Well, when I was walking around the table like this, I accidentally tripped and hit my eye on the table.
Oh, no.
I know.
Well, glad you're okay and you're smiling.
Thanks.
Okay, so that's your only injury, huh?
Well, my cheek hurts.
Okay, so we have orders for all the above, so we'll go ahead and get you started.
I don't know why I'm doing the sinuses, but I think my doctor says I have something wrong with my voice.
So I have I've shielded my patient from the back and from the front, and I have my tube perpendicular to my 15-degree angle IR for my axial Caldwell projection of my sinus, and we're doing these all upright to show the air fluid levels. My range for my exposure is going to be about 70 to 80 kV at around 6 mass. And so with the IR tilted 15 degrees, I'm just going to have her place her forehead and her nose on the board, and this places the OML perpendicular to it. And the center ray enters and it exits the nasion.
Showing.
This beautiful Caldwell method shows the frontal and anterior ethmoidal sinuses.
It sure does.
I have my patient set up for my waters method, which will show the maxillary sinus. I have her chin resting on the IR, which forms the mental meatal line perpendicular, or the IOML forms a 37-degree angle with the IR. And for this projection, for the waters projection and the Caldwell, I'm going to go ahead and use an 8x10. And the technique again for this one is around 70 to 80 at about 6 to 8, 10 mass. And the center ray is horizontal and exits the acanthyon. So I've asked my patient to hyperextend her head, and this places the IOML parallel to the IR, and mid-sagittal plane is perpendicular. The center ray enters the sella turcica about 3/4 of an inch anterior to the EAM, and this is the SMV projection, and it shows the ethmoid and sphenoidal sinuses. And technique again is about 70 to 80. Nothing's really changed, 5-6 mass. So I have my patient in the lateral position. I'm going to go ahead and center the mid-sagittal plane parallel to the IR, ensuring that the inner pupillary line is perpendicular to the IR. IOML is perpendicular to the front of the IR, ensuring that it's a true lateral. Center ray is horizontal and it enters the patient's head 1/2 to 1 inch posterior to outer canthus. And this shows all of the sinuses and range again for this particular lateral is about 70 to 80, about 6 Mass. Have you started?
Yeah.
Okay, I have my patient set up. I have a 25-degree angle for all my mandible projections. This one is a PA axial. Her chin is touching the IR, and this places the OML perpendicular to the IR, and the center ray enters and exits the acanthion, I'm sorry, not nasion. This shows the mandibular body and rami. The technique range is about 70 to 75 at about 8 to 16. And I have her perfect. For these mandibular views, I'm going to go ahead and keep the 25 degrees cephalic angle. First projection we're going to do is Ramus, and this is an axial lateral. I'm going to go ahead and have her in a true lateral, and this shows Ramus. And technique is about the same for these, 70 to 75, 8 to 16 Mass, and the center ray enters the gonian. Mandible projection of the mandibular body from the true lateral that we had showing the ramus. I'm going to go ahead and just slightly rotate her head 30 degrees toward the IR, which shows the body. I have still a 25-degree cephalic angle on the tube, and the center ray again enters the gonian, and range has not changed for the technique. And for my last mandibular view of the mandibular symphysis, center ray enters once again the gonian, and only the slight angulation is going to increase from 35 to 40, sorry, to 30 to 45 towards the IR. This shows the symphysis. And technique range again, 70 to 75 at about 8 to 16 Mass. I'm going to go ahead and do my orbit series now. I have my patient resting her chin on the IR, which forms the mid-sagittal plane perpendicular to the IR. This places the OML to a 50-degree angle with the IR. Center ray enters through the orbits, and this is done to show if any foreign objects are in the orbit. Since we're not using a grid, it's just straight on IR, I'm going to go ahead and use a lower technique at about 70 to 75 going to go ahead and shoot the orbit since it's non-grid, a little lower than what you would normally do for grid. It's about 60 to 70 kV at about 4 to 6 Mass.
Is it okay that my neck's up like this long?
Right and left laterals for comparison, and these orbits are done since she did something to her eye, and you want to make sure that there's no foreign bodies in them. So go ahead and center ray enters the outer canthus,
Please don't wipe your nose
and
touch me.
inner pupillary line is perpendicular to the IR, so that it is a true lateral. And this is my right. Same one as before, about 60 to 70. And now I've done my right lateral, so this is my left orbit lateral. Center ray again enters at the outer canthus, right here, aka crow's feet. Inner pupillary line is still perpendicular to ensure that we have a true lateral. Mid-sagittal plane is parallel, and this is done to show if any foreign bodies. And the technique is about 60 to 70 again without a grid at about 4 to 6 Mass. And now I'm going to start with critiquing the images. I'm going to start with the orbits. So we start with the right and left lateral for comparison. Here is the picture. We should show enough density and contrasting so that the orbit is optimally visualized to see for foreign bodies. We should see superimposed orbital ribs and a close beam restriction collimation. And now for the parietal-acanthial projection, also known as the modified Waters method, this again shows we do this to show for any foreign bodies. We want to have the petrous ridges lying in well below the orbital shadows. Symmetric visualization of the orbits indicating no rotation of the cranium, and close beam restriction. Starting with our mandibular views, we have the PA axial projection. Here it is. This shows the mandibular body and rami symmetric on each side. Shows the condylar processes, and the entire mandible is what you want to see for this projection. Here we have an axial lateral projection of the mandibular body. Here we have an axial lateral oblique projection of the mandibular ramus. And lastly, there we have the axial lateral oblique mandibular symphysis. For the ramus and the body, you want to make sure that there's no overlap of the symphysis, and no elongation or foreshortening of the ramus or body, and also ensure that there's no superposition of the ramus with the cervical spine. For the symphysis, you want to make sure there's no overlap of starting with our lateral projection of the sinus, which should show all four sinuses: the frontal, the ethmoid, the sphenoid, and the maxillary. Here it is. We should go ahead and obviously see proper collimation, and once again show all four sinuses, but primarily the sphenoid sinus is the one of interest. You want to make sure that there's no rotation of the sella turcica, superimposed orbital roofs, clearly visible sinuses, and superimposed mandibular rami, and make sure that there's clear visualization of the air fluid levels if present. For our parietal-acanthial projection, also known as the Waters, we should go ahead and see proper collimation. Petrous ridges lying immediately inferior to the floor of the maxillary sinus. You want to go ahead and see equal distance between the lateral border of the skull and lateral border of the orbit on both sides. Indicates no rotation. The orbits and maxillary sinuses symmetric on each side. This one primarily shows the maxillary sinus, and clearly visible air fluid levels if any are present. For our lovely and most comfortable position for the patient, we have the SMV, and this goes ahead and shows the ethmoidal and sphenoidal sinuses. You want to go ahead and see proper collimation again, and make sure that there's equal distance from the lateral border of the skull to the mandibular condyles on both sides, indicating that the mid-sagittal plane is perpendicular and there is no rotation or off-center. The anterior frontal bone superimposed by the mental protuberance, indicating that the IOML is parallel, so that means that it's fully extended the neck. The mandibular condyles anterior to the petrous ridges, and any clear fluid levels if present. And that's all.